Okay, so we talked last time about the respiratory membrane, what things make up the respiratory membrane. So I'm going to give you the answers to that ultimate question. The respiratory membrane is made up of two things. So I have everybody's paper. Okay, I need it. You got everybody's paper? Okay. Two things that make up the respiratory membrane are the walls of the alveoli and the walls of the pulmonary capillary. So I see that a lot of you have that. That's great. And things that thicken it, that make it more difficult for carbon dioxide to leave the blood and enter the alveoli to be exhaled, and for oxygen to leave the alveoli and enter the blood to feed the tissues, is fluid, scar tissue, mucus, tumors. So those are big things. And so one more thing, broken down alveoli from COPD, emphysema. When those simple squamous cells simply break down, there's no respiratory membrane in that case. So 5 different things. Again, cancer, tumors, fibrosis, scarring, fluid, emphysema, or not emphysema, breakdown of the wall as a result of emphysema. And I forgot the 5th thing I said now. Alveolar collapses from emphysema. So maybe there's 4. But anyway, those are the big things that people are hospitalized for, that we need to give them oxygen support for. Some things we can fix, some things we can't. Inflammation is something that's a temporary situation, that when people just get sick and have a bad cold, they get inflamed airways, inflammation in the lungs. We give steroids for that. And we give it through the IV. If they need powerful steroids, we give it through the IV. There's certain inhalers that are steroids, like Symbicort, stands for cortisone, which is the cort part of it is cortisone, which is a steroid. So there's things we can do to help with that. But in some cases, like tumors, absent alveolar walls because of emphysema, that we can't fix. And those people eventually succumb to their disease if they don't stop the damage. So when we look at blood supply, we talked about that. It's a low pressure, high volume supply from the heart to the lungs and back to the heart. Remember, the pulmonary artery carries deoxygenated blood. Pulmonary vein carries oxygenated blood back to the heart, because we define artery and vein as directional flow. Arteries always carry blood away from the heart. Veins carry blood to the heart. We don't define artery and vein by oxygenated, deoxygenated, because there are some exceptions to that rule. It's always directional flow. Arteries are always away from the heart. Veins are always to. We talked about the pleural fluid that is in that space between the parietal pleura and the visceral pleura. And remember, that's always a negative value. The pressure in that fluid is always negative because it's always being slightly pulled apart, which drops the pressure. When I increase the volume without decreasing the stuff inside of a space, when I increase that volume with a little bit of pull of the chest wall outward and pull of the lungs inward, that causes the pressure to drop and always be negative. And that's a good thing, because that's what keeps the lungs inflated. If we don't have that stickiness between the parietal pleura and the visceral pleura and that negative pressure in that fluid, the lungs are going to collapse. And if the lungs collapse, we oftentimes will need a chest tube inserted into that space to create a negative pressure. It's hooked up to suction on the wall, and that creates a negative pressure to keep the lungs inflated until that heals and they can stay inflated on their own. We talked about intrapulmonary pressure is pressure within the alveoli, and that has to change in order for air to flow. So that's what we left off with last time, talking about ventilation and how the pressure goes in the opposite direction of the pressure in the outside air in order for air to flow. For example, if the pressure of the outside air we just set at a generic number of 0, the pressure in the alveoli has to be what? Greater than 0 or less than 0 in order for air to flow? So we have pressure in the outside air. If this is 0, I'm just using that as a generic number. If 0 is the same thing as 760 millimeters of mercury, which is atmospheric pressure, a little coffee twitch there. What would in order for air to flow in, what would the pressure inside the alveoli have to be in order for air to flow in? It would have to be what? If it's positive, air flows from high pressure to low pressure. So if this is 0, that's where the air is. We want air to flow in. So if this is high, this has to be low, which means it would have to be negative. It'd have to be a negative value in order for air to flow into the lungs. And it's going to flow in until what? Till it's equal. Until it's equal to atmospheric pressure. And then the muscles are going to relax. We talked about that, right? The external intercostals relax. The diaphragm moves up, decreases that volume. What happens to pressure when we decrease the volume? It goes up. Now it's higher than outside air, and air flows out. So the really only active process when we look at the movement of air in and out of the lungs is the inhalation process. Would you agree? Because we need contraction of the external intercostals and we need contraction of the diaphragm. And then from there, it's a passive process. Then we just turn off those muscles, they relax, volume goes down, pressure increases, air flows out. So when we try to help people that have fibrotic lungs and poor ventilation, sometimes we have to change those pressures with a machine outside the body to get the air to go in and out effectively. So we hook people up to what's called a Bipap machine, and we talked about that. I talked about it a little bit last time. And it's a full face mask, so we can control the inhale and the exhale for people that have really bad lungs, and I'll show you what it looks like. And people don't like it because it's not comfortable. Here's a classic picture of what a Bipap machine looks like. So really good story is we had an elderly woman came in, her CO2 levels were really high because of fibrotic lung disease, and she was not blowing off CO2. And if we don't blow off CO2, CO2 turns into carbonic acid, which contributes to a low blood pH, and that can kill a person. So she would come in with really low blood pH, very lethargic, unresponsive because of really high CO2 levels. So they would put this mask on her, and then after a couple days of the mask, the CO2 levels would go down, oxygenation would go up, and she'd be discharged. And all was right with the world. Well, then she came in again, put the mask on, but her lung disease had advanced and the mask wasn't working anymore. So the doctor came in and explained that to the daughter. You know, her CO2 levels aren't coming down with the mask, so we're gonna put her on palliative care. We're gonna remove the mask, because that was what her wishes were. She said, do not resuscitate, and the mask isn't doing the job, so we'd like to take the mask off and just go palliative and give her morphine to control the stress of low oxygen. When our body is low oxygen, it causes us to be anxious and breathe more rapidly, right? But morphine blocks that response. So it helps people that are dying of lung disease to be comfortable when they have low oxygen levels. So the daughter was very upset about that. So the doctor left. She thought the conversation went well. The daughter was livid. She said, so you guys are just giving up on my mother? Because I came in totally oblivious. Hi, how are you? And she was totally upset. And she's like, so you guys are just giving up on my mother? She said, you know, this mask works. We just got to keep it on. Why are you taking that off my mother? I'm very upset. The doctor came in and just said, we're going to go palliative now. My mother was, you know, we were walking and talking to each other just last week, and now she's dying, and that's it. And then I pulled up her x-ray and showed her lungs were completely white with just solid scar tissue. And I said, well, what's happening? And again, this is where a little bit, you don't have to be experts in A&P, but just a little bit of basic A&P knowledge. I said, the oxygen that we're giving her with the mask and the CO2 that needs to come out of her blood through her lungs, it's like hitting a brick wall now. In the past, there were holes that we could get through. There was a little bit of life in those lungs, and we could get those gases to exchange across her lungs. Her disease has advanced. It's a brick wall now. So now we're pushing air into a wall that it can't pass through. And how would your mother like to live her last years? Now, we put the mask on. The lab results from her blood show that the CO2 levels are still really high, oxygen is low. How would your mother like to spend her last few weeks or whatever time she has left? She can't eat, she can't drink, it's uncomfortable behind that mask. She can't talk to you or hear you because it's with that mask. How would she like to spend her last years? Would, eating and drinking the things she enjoys, being comfortable with morphine, that's where the doctors are at, and that's what the palliative team have come up with. And she's like, oh, well, that makes sense then. Okay, well, thank you for explaining that to me. Done. That wasn't even amazing physiology explanation, right? But just sometimes doctors aren't real good at explaining the physiology of things, and patient families get really mad. And we walk into that, right? Some of you guys that are working in healthcare, have you ever had that happen? Oh, yeah. Like, what does RN stand for? Are you a real nurse? That was another patient family that said. I'm like, oh my gosh. And I forget what they were livid about something. And again, just explaining in a real simple way that a person can understand, okay, yeah, that makes sense. And being calm and recognizing, yes, I understand your stress. I understand, yeah, this is your mother. I totally get that. Last week she was healthy, this week she's not. That's how lung disease goes. And it's really unfortunate. But, you'll have some good quality time with her without the mask. So, back to this. So these pressures then, we have pressure in the lungs, that's intrapulmonary, pressure in the pleural space, intrapleural, and transpulmonary is the difference between those two. And we're not going to spend a lot of time talking about transpulmonary pressure. I think it's a little more advanced of a concept. I think if you understand the pleural pressure, the transpulmonary pressure, intrapleural pressure, intrapulmonary pressure, and atmospheric pressure, those are the key things we need to know as healthcare people. I learned about transpulmonary pressure in grad school, and this is not a graduate physiology class, so we're not going to go into that detail. We talked about the term atelectasis. Sounds like a girl's name, doesn't it? But that is lung collapse. So when we don't get enough air into the alveoli, eventually moisture levels build up, and the water droplets that line the alveoli are attracted to each other. They want to form a droplet, and the alveoli collapse. So people that have really bad bronchitis and plugged bronchioles with mucus and restriction end up with collapsed lungs. So that's a very serious side effect. Kids with cystic fibrosis, where they have increased mucus buildup in their airways, have a big problem with collapsed lungs, and they have to come in and get that resolved. Anything that causes air to enter the pleural cavity, so gunshot wounds, stab wounds, fractured ribs in a vehicle accident, football, soccer, some of those sports, we got to think about that, because some of you are going to be parents and coaches, and a kid comes to the side of the field after getting punched in the ribs and really has a hard time breathing. We got to think about maybe a fractured rib and a punctured lung. There have been kids there's a story of a kid in Milwaukee when I went to school that he died on the school bus after a football game. He was kind of a whiny kid that was a little dramatic when he got hurt in football, so people were kind of ignoring him. He's like, oh, it really hurts, I can't breathe, and okay, just sit down, you'll be fine, right? Because he whined a lot. He ended up dying on the bus by the time they got to their school, yeah. So it's very serious when we look at that. And when I was giving a talk, ironically, to my church on the importance of vaccination, a couple of nurses and I were parish nurses, like church nurses, and I was talking about the importance of getting your flu shot, and this was 2 years ago, and we just started our talk, and then all of a sudden there was an older woman that was puttering around in the kitchen, finishing up, cleaning up after we had our little luncheon. All of a sudden she's going, and she's like grabbing onto the counter, and I'm like, what the heck? And she's like, she's choking. So we run over there. One of the nurses is a very tiny lady, and this woman was a little larger of an older woman, so she tries to get around her, just does a little, and couldn't get anything. She's like, Jill, why didn't you try it? Like, okay, well, I would have been told to not spare any strength when you do that, because you want to clear the airway. Whatever else happens can be dealt with. The airway is number one. So I got around her and I went really hard, and boom, came out right away. But as I did it, I felt a in her ribs, and I was like, oh no. And I said, so she was like, oh, she was breathing. I said, oh, thank goodness, are you okay? I'm fine. I said, well, I felt a little crack when I did that, so be careful and pay attention to that. Oh, no, I'm fine, I'm fine. Well, when you first break a bone, sometimes you don't really notice that it's broken. So I called her that night, and I said, how are you feeling? Oh, I'm feeling pretty good. I got some pain on the right side there. I'm like, that's where I felt the crack. And I said, well, if that doesn't go away, you should probably be seen, because, I likely broke a rib when I did that. And she said, oh, it's perfectly fine, no big deal. She says, thank you, I'm glad that we didn't have to call an ambulance, and it could have been a lot worse. I'm like, yeah, okay. So then the next day, someone else told me she did go to the doctor and she did have a broken rib, but she never even told me about it, which was really sweet, I thought, to not make me feel bad. But again, and cracked ribs are definitely a side effect of doing the Heimlich maneuver, but you have to do it. You don't want to waste any time with that, because without air, how long can we survive? 5 minutes? And then we're down, and that's it. So my dad, when he was in the police force still, they were in court one time, and a lawyer came up to the podium to talk to the judge, and must have had a heart attack or something, and just fell over right there, and everybody sat there and watched. And then finally someone said, we better call 911. And they called 911, and he just died in front of everybody. So we have to respond. And we all know enough to respond, right, in a simple way. Like if someone's choking, you grab your hand around them and you get under the ribs and you just push up, and you do it really fast. So you don't put your hand out here so you're punching them in the stomach, right? You keep the contact, and then you just squeeze and push up as hard as you can, even if you lift them off the ground a little bit. I've never done the Heimlich maneuver before. I did it just the one time on that lady, and it was successful. So that's what matters, right? Oh my. Right. Yeah. Yeah. Did it work? It worked. Yeah. And you got to do what you got to do. Yeah, and not be afraid. And I have a student that I had in prep for A&P that was at Black River Beach just hanging out with some friends. She was early in nursing school, and family was swimming around, and the 2-year-old went out too far and was swept under the water in the river, and everybody was screaming. I don't know if people didn't know how to swim or what happened, but she stood around and saw that nobody was doing anything, so she ran in the water, grabbed the boy out, and he was unresponsive, lifeless, put him on the sand and started doing CPR and brought him around, and he's alive today because of that. So you'd be amazed when things happen how people just don't do anything. I had to do CPR, not a CPR, but first aid, like initial response to a student. She walked out of class one time, and I didn't notice her walk out. It was during a quiz, and all of a sudden I heard a ta-doom and a slide of like a chair, and I was teaching, and I thought, I don't know what caused me to stop and see what was going on in the hallway, but I did, and there's this student laying flat on her back like this, unable to breathe because she was flat on her back. And what happened is there was a chair that was to the side that she tried to grab onto, and when she passed out, it slid. So I came back in, and I pointed to a student, I said, call 911, we have an emergency. And then another student came out who worked in the ER, and we rolled her. And I was 9 months pregnant at the time. But I got on my hands and knees, and I rolled her on her side. And as I rolled her on her side, my hand was covered with blood because she had staples, or not, she needed staples to repair. She had split her head wide open by falling straight backward. She had a concussion. She had just a really rough semester. But she was sick. She was sick and weak and was going to throw up in the bathroom and passed out on the way there. So yeah, it was serious. But she's a paramedic today. So she was a good student. Anyway, so back to this. So we talked about these pressure changes. We have to change the volume before we can change the pressure. So remember, number one is we have to change the volume before we can change the pressure in order for air to flow. So what happens first is we change the volume, then we change the pressure, and then lastly, the third thing that happens is the gases flow until they're equal, and then we switch from inhalation to exhalation. So volume changes first, and what changes the volume? What do we need to change volume? What does the volume changing? What structure, what system is working to change the volume? The muscular system, yeah. The diaphragm and the external intercostals. If those are not working, we have no inhalation and exhalation. And that's what was the big thing with polio. Polio caused paralysis of muscles years ago. 10%, polio is a GI illness. It's a diarrhea gut illness from bad water. But when 10% of patients that get polio end up having it infect their nervous system, and it does damage to the control of muscles. So as a result of that, their muscles don't work for breathing, and they have to go in an iron lung. So an iron lung is changing those pressures by changing the volume for that patient. So that was a big deal, and people didn't survive if they didn't have that iron lung. Have you ever seen what the iron lung looks like? This is a problem, not a current problem, right? Because we've taken care of it. But this is what they used to look like. That machine. Think of living like in one of these for months while you recover from polio. And that's what people had to do. And nurses had to provide care to them while they lived in that. Here's an example. This is what lack of vaccine looks like. This is before the polio vaccine. Look at all those people that the nurses had to tend to. I was thinking the same thing. I don't know. I haven't spent enough time to research it, but you can look that up if you want. Okay, so some things that affect the ability of our lungs to move air is the resistance in the airways. So if you have asthma or bronchitis, that's going to increase airway resistance. It's going to be resistant to the movement of air. Alveolar surface tension, and surface tension is the inward movement of the alveoli due to water, because water wants to attract, or is attracted to other water molecules and wants to form a water droplet. And then lung compliance deals with the ability of the lungs to move with the chest wall. So if I look at these two, they kind of fight each other, and we'll talk about it a little bit more here individually. So airway resistance is anytime we have constriction or obstruction of the bronchioles, that is going to increase airway resistance. So that's going to increase resistance. So if someone is having an allergic reaction because of a severe peanut allergy, that is going to prevent any kind of CPR efforts from being successful, because when you try to blow into their mouth, if those airways are shut down, we can't get oxygen into those alveoli, and that person's going to die. So that in that situation, CPR is not going to save them. What's going to save them is epinephrine, which we know dilates the bronchioles, and that's going to reduce airway resistance. So we need to have an EpiPen. And if you know someone who has a severe food allergy, they should have an EpiPen and not take that for granted and say, oh, it's too expensive, or oh, I left it at home, or I have one somewhere. There's a lot of people that's how they operate, and that can be life-threatening. And I think I told that story, right, about the girl at the camp who died from the peanut allergy. Very, very sad. Right, yeah, because they're so expensive, and they do expire, and it's just a really unfortunate thing. We need to bring the price of those down. I really wonder how expensive it is to make epinephrine. I don't know, but it seems a little ridiculous. So alveolar surface tension, this acts to, the benefit of surface tension is it causes the alveoli to shrink. So when we're done inhaling, we have to have some forces to allow the lungs to shrink, to allow air to leave the lungs, right? So we don't want to have nothing acting inward on the lungs, otherwise they would stay expanded. So this acts inward. So surface tension promotes exhalation, acts inward on the lung, because it's the water molecules that line the alveoli that are attracted to each other. So it promotes exhalation. Oh, I cannot write today. Ooh. I work at the county jail. I told you, on call, and my boss over there was a former student in advanced A&P. And I told her, I said, I have terrible handwriting. And after looking at the paperwork at the jail, she said, yeah, I didn't realize how bad your handwriting really was. Like, thanks. She said, when you were teaching, I didn't notice you had bad handwriting. I said, well, that's because we type everything. And that's why I have bad handwriting, is I type everything. So if you don't use those muscles, you lose it. So that's the, when we don't have paper charting, like at Gunderson, there's no paper charting. Everything is typed. So if you have paper charting, it at least helps your handwriting skills. But I don't work enough to. Yeah, well, yeah, this is terrible. Yeah, my handwriting's not this bad. Okay, so surfactant fights surface tension. So this is a special lipid-protein combination molecule, and it's produced by those type 2 alveolar cells, and that reduces surface tension, and that prevents the alveolar collapse. So this acts outward on the lungs. So if I draw a picture of a lung here, surface tension acts inward, causing the lungs to want to deflate, and surfactant fights that and acts outward on the lung to keep them inflated. So kind of like if you're making bacon on a pan and you have all that oily bacon droplets and you need to break it up and get rid of it, you add soap to it, right? If I just add cold water, that's not going to clean your bacon pan. But if I add soap and I only have cold water, that's going to break it up. So that's kind of like what surfactant is. It's a detergent-like substance that breaks the water droplets in the alveoli, so the alveoli don't collapse with that water inside of there. And this is what they do to women that are going into preterm labor. Maybe you've heard them say, yeah, they're giving her a shot to help develop the baby's lungs. Well, it's not necessarily developing the baby's lungs, it's helping the baby's lungs have more surfactant available. So when that baby's born, the alveoli can expand and they're not going to collapse with all that moisture inside those lungs. Because babies don't really have good surfactant production until later on in the pregnancy, closer to birth. And the squeeze of childbirth going through the vaginal canal promotes surfactant production. Anytime we put pressure on the lungs or we take a deep breath, that stimulates surfactant production and keeps the fluid from building up in our lungs and causing them to collapse. So that's why when we have patients that are sick and are sitting in a chair or sitting in a bed and on lots of pain meds, we need them to use their incentive spirometer, even if they're not a lung patient, because any patient after surgery that's weak and sitting around all the time is going to have collapsed lungs in the bases of their lungs because they're not taking deep breaths. So you have to tell them to use that incentive spirometer and take deep breaths. The same thing with you guys. When you're studying and sitting and crouched over your table after, and people are leaning back now, stop and take a deep breath and hold that air and let it diffuse. Because sometimes when we're stressed too, we tend to lean over and we take short, rapid breaths, and that builds anxiety because you're getting a little low on oxygen. You know, they talk about deep controlled breathing reduces anxiety, promotes release of relaxing neurotransmitters. There's a lot to be said for that. And being in class, taking a test, taking that NCLEX when your time comes is very stressful. Sitting back, filling your lungs with air, holding it for a little bit and slowly letting it out, reduces anxiety, increases oxygenation, helps your brain function. And your patients need to do that as well. We even find that patients that have small lung collapses because of sitting around a lot and not doing deep breathing, they can actually develop mild fevers. And we can think they're sick when actually they're just having small collapses in the lungs and they need to do some deep breathing, and then the temperature will go down. And that's something that I never learned in nursing school and was never taught in a textbook, but it's observed on the nursing floors. And some older nurses told me that. I'm like, my patient's got a fever and they're discharging. What should I do? Have him blow on his intensive spirometer. I was like, what? That doesn't make any sense at all. And sure enough, she was right. I asked around, and there is something to be said for that. You could probably research it and find the physiology behind it, but it's not a common thing that we know going into nursing, but once you get there, you'll observe that. Okay, so surfactant. Deep breathing promotes surfactant production. When babies are born really premature, we give them oxygen support and surfactant to help promote the breakdown of those water droplets in the alveoli and promote lung expansion after birth. Sometimes, though, that positive pressure that we're giving to those tiny little fragile preemie lungs does damage to the lungs. And that's why preemies tend to have lifelong lung issues, because of the support we have to give them to get them going also does some damage too, because those pressures are higher than what normally would happen were they full term. And again, the squeeze of childbirth is a good thing for babies. So some babies that are born C-section need a little oxygen support because they didn't get the squeeze from going through the birth canal. And babies that are born in the water, that are born real gentle and don't get a lot of squeeze and don't cry, people in the old days used to smack babies on the butt to make them cry and fill their lungs with air. And that too promoted surfactant production. So a crying baby after birth is not a bad thing because of that. Another thing is some women get it, depending if you have a more sensitive or irritable uterus or not, but some women get a lot of Braxton Hicks contractions, which are those fake contractions that don't lead to birth, but they're kind of annoying, and they start about 7 months and go up until childbirth. That squeeze of the baby when those fake contractions happen also promotes surfactant production. So that's a good thing. Annoying for the female, because I had a lot of those with all of my kids. I had a super sensitive uterus, and it's uncomfortable when that happens. I mean, the stomach, the belly is out here, and when you get in a contraction, it like rises up, and it's hard as a rock, and it's like, oh my gosh. When it's your first pregnancy, you don't know what that is, but it's harmless. You have a question or comment?
I did. In regards to preemie babies, or just children in general that are born with these little, say they have asthma, something like that,
Hereditary.
what happens to the levels of it?
Like childhood asthma?
Like for example, my oldest, being 8 weeks preemie, he had asthma for, I don't know, like at first, when he get a cold or sick, we had nebulizer at home, so we got a nebulizer and stuff like that, like a infant and stuff like that. And then as he got older, he was able to just use an inhaler as needed. And now it's been like 2 years. Well, it's about 18, so it's been about 3 years now.
Yeah.
He hasn't needed anything. I mean, as long as he's resting,
That's great. Well, I think in general, the immune system gets stronger as we age. We're catching less stuff, and we're recovering better as we get older, because kids are always sick, right? And they're always sometimes going from one cold to another cold, and you have that constant airway inflammation and resistance. And also the airways are bigger. So as you develop and become an adult, just like ear infections, right? Kids get chronic ear infections and become an adult, and the ear infections go away because those eustachian tubes become more vertical and larger. So if there is some inflammation or a little infection in there, they don't shut down and clog the middle ear with infection. Same thing with asthma. He could have some reactive airway, because his airways are bigger now, he doesn't feel the effects of that being an adult. And that's great. And also with all the good treatment he got as a kid, that may have made his airways less reactive too over time, which is good. Oh, wow. Oh yeah, surfactant then. That would be surfactant. Yep, yep. Mm-hmm. Yeah, and sometimes what is that, mag sulfate they give women to stop the contractions, early contractions. I think that's what it is. But is that what it is? You know what that? Yeah. And it makes people really uncomfortable. It's horrible for the mother, but it keeps the uterus calm and helps give baby some time to develop. Yes. Yeah. I'm glad you mentioned that. That is true, because I noticed that in myself, that low hydration increased the Braxton Hicks contractions. And A lot of activity too, like being on your feet too much would cause it. And I have a niece right now that's a nurse practitioner. I think we talked about this, right? Who's due like in April, but she's having twins, and she's very tiny with a short torso and these big babies, so she might be having them any day now. And that's a concern for her is, you know, are they going to be developed enough to be born if they decide to come earlier than the plan? So she's drinking lots of water and watching her carbs and trying to stay off her feet. Anyway, so back to this, lung compliance. So this definition is from your textbook. I think it's a little confusing. So the way I would say to remember this, it's the ability of the lungs to move with the chest wall. So the ability of the lungs to move with the chest wall. You should write that down so you understand what this means, and if you see it on a test, you'll remember. Ability of the lungs to move with the chest wall. And think of it, compliance. If I say, come with me, we're going to go in the hall. If you're compliant, you would come with me and go in the hall, right? If you're non-compliant, then you wouldn't, right? So same with our patients. We have patients that are compliant with what we ask them to do, and there's ones that are non-compliant. So lung compliance is the ability of the lungs to move with the chest wall. So what direction does compliance act on the lung? If a lung has good compliance, which direction, if we're looking at forces on the lung, what direction would compliance act? Yeah, outward, yeah. So when we inhale, the lungs move with the chest wall, right? So the lungs are compliant. So factors that increase lung compliance is a low alveolar surface tension and a stretchy lung, okay? So compliance promotes inhalation. So if a person has emphysema and blown out alveoli, they actually have really compliant lungs because the lungs flare out and they have this barreled chest. But they can't exhale. So they can inhale fine, but they cannot exhale. And if you want to know what emphysema feels like, perfect analogy next time you're drinking with a straw is try to just breathe normally through a straw. And you're going to find yourself, after a couple of breaths, you're going to feel like you're not able to get that air out. You can get the air in through the straw, but you're not able to get enough air out, and that's how emphysema feels. So this promotes inhalation, but if we have too much compliance, we can't exhale. So if you have a fibrotic lung, or if you have not enough surfactant, or if you have an inflexible thoracic cage, as we age, the cartilages that attach the ribs to the sternum start to stiffen, and people can't inhale or exhale as well, so compliance goes down. And again, that's why when they get this, heaven forbid, coronavirus or influenza, they can't clear their airways. They can't take deep breaths to maintain their oxygenation when they have this fluid in the lungs from the coronavirus, and they're really at risk of death. Now I read last night someone in the cities in Minnesota in their 30s died of the coronavirus. And what was that about? Does anybody know the details of that person? Would they? Yeah. Okay. Was it in Minnesota? Oh. Oh, what can you tell me?
She was like, there's somebody who's 30.
Oh.
You can't go anywhere.
Oh, right. Yeah. In Wisconsin, confirmed? Yeah. Is that in Madison or? I heard about that one. Okay. Now, they have? Oh my. Yeah, it's coming. All right, so back to this. Emphysema increases compliance, again, because... Yeah, and the big thing in the news is the president needs to be tested, and he refuses because he shook hands with a couple of people that had it. So they want him tested, and everybody's screaming, and he's not getting tested, and oh my gosh, drama. Yeah. Right? Yeah, yeah. They're talking about the NCAA, you know, the March Madness is gonna not have an audience. You can watch it on TV only. So that's gonna be a big deal. In the summer? Oh my gosh. Wow. Okay, back to this. I'm recording here. So when we look at what's in the alveolar gas, what's in the air we breathe, the alveoli have more carbon dioxide and water vapor than the atmospheric air because of the diffusion from the blood, constant feeding into the alveoli. So we're going to have more carbon dioxide in the lungs than outside the air, and the water vapor. And the water vapor, where does that come from? The water vapor in the lungs comes from the mucus that lines the airways. Mucus is mostly water. If you have healthy mucus. Now, if you're an older person, what happens as we age is the water content of the mucus goes down, and mucus is more dry and sticky in an older person. Again, putting them at risk of complications of influenza or coronavirus because they can't clear their airways. So we need to, you know, help them with that and make sure they're well hydrated, and they tend to be less hydrated as well, and that contributes to thick, sticking mucus. So when you hear people say, oh, you're sick, drink plenty of fluids, there really is something to that. You do need to drink plenty of fluids, because think of what's happening. If you have a snotty, runny nose and it's just dripping and you're blowing your nose constantly, you're losing a lot of water through your nose, through your drippy, runny nose. So you need to replace that by drinking lots of fluids. And a thing that I do, because sometimes when you're producing a lot of that thin mucus that's really watery, that turns into kind of thick, sticky stuff in your lungs later in the cold. You ever notice that? You have a upper respiratory infection, turns into a lower respiratory infection. Taking an antihistamine to dry up that watery stage will make less mucus production that'll settle in your lungs and cause a residual cough for months and months and months. So whenever I get a drippy, wet nose cold, I load up on antihistamines for 4 or 5 days, and then that shortens the cold and keeps me functioning while I'm working here. So anyway, looking at the combination of gases in the atmosphere, we have a lot of nitrogen gas in the atmosphere, but we don't need that in our lungs for, you know, feeding our cells. So it's all about the oxygen and the carbon dioxide. The oxygen is what we need. So if we look at the percentage in the air compared to the alveoli, there's more in the outside air than the alveoli. More carbon dioxide in the alveoli than in the air. So if we look at the, you know, the combination of different gases leading up to 100%, there's more oxygen than carbon dioxide in the alveoli at any one moment, and that's good because we want a rapid diffusion out of the alveoli into the lungs, or into the blood, sorry. So, and again, the nitrogen gas is not useful for feeding tissues. So this respiratory membrane is where this exchange happens, and it's all about diffusion. Nothing fancy. To get those gases from one side of the membrane to the other, I'm writing it real big because it's going to be on your test. It's simple diffusion, no energy required. It's diffusion from high partial pressure to low pressure. And these are gases, so that's why we say pressure, not, I mean, we could say concentration, but the concentration is measured in pressure. And it's because these are gases. So it's the pressure, the unit is millimeters of mercury when we're talking about concentration of oxygen and carbon dioxide. So again, it depends on structural characteristics of that membrane, ventilation, perfusion, coupling. So what that means is perfusion has to do with blood vessels. So if we have good blood flow to the lung, we have good ventilation to the lung. But our body is really smart. If we get filled or collapsed alveoli, the body shuts down and reduces blood flow to those bad alveoli and directs the blood flow to the good alveoli. So these capillaries are actually responsive to the gas exchange that's occurring with them. And if gas exchange is impaired, those capillaries constrict and the blood flow is redirected. So that's what we call ventilation perfusion coupling, is just that relationship between the respiratory membrane, the alveoli and the pulmonary capillary, responsive to one another, so we're not wasting blood to a part of the lung that's not functioning. Okay, so looking at this a little closer then, key things I want you to know is, where is oxygen the highest? So we've got the alveoli in the lungs. This is the pulmonary vein, bringing that freshly oxygenated blood back to the left side of the heart, down to the ventricle, up to the aorta, and this would be the, what? Thoracic aorta, abdominal aorta, all the arteries serving the organs. This is a real simplified diagram. So these are all the arteries that branch from the aorta that feed the body, dumping off oxygen to the tissues, picking up carbon dioxide because the tissue cells are undergoing metabolism on all parts of the body and producing carbon dioxide, right? So that diffuses from high concentration here to lower concentration here. It's carried back by the veins to the heart, to the right side of the heart, and it's pumped up to the lungs, pulmonary artery, going away from the heart, where that carbon dioxide diffuses out. So that's kind of the circuit between the heart, the lungs, and the body tissues. So possible test questions. Where is the PCO2 the highest in the body? In this diagram, what location is the partial pressure of carbon dioxide the highest? Very good, in the tissues. So that's the highest. Where in the body is the partial pressure of oxygen the highest? Put a little asterisk. Yep, in the alveoli. Ooh, there we go. In the body, right? So make sure you pay attention to those two locations, because without that, we're not going to have that constant pressure difference for diffusion to occur. Now, if I look at the partial pressure of oxygen in the alveoli is 104. In the pulmonary veins, it drops to 100. Where did that little bit of oxygen go, do you think, between the alveoli and the pulmonary veins? Not yet, because it's just going from here to here, and it dropped a little bit. Yeah, to the lung tissues, because they need oxygen, right? Those are living cells. The simple squamous cells of the lungs are living cells. Those type 2 alveolar cells that are secreting surfactant, they need oxygen to do their job, right? So we do lose a little oxygen just to feed the lungs itself, because it's a living tissue. And then if we notice, when it goes through the heart, does the heart get, is there any drop there? No. Now we do have the coronary, we're going to study in the cardiovascular system. At the base of the aorta, we do have the coronary arteries that serve the heart muscle and give it oxygen, and that hooks up with the cardiac sinus, or the coronary sinus, that goes right to the right atrium. So the blood supply to the heart muscle itself is called the coronary circulation, and that goes right from the aorta, serves the heart muscle, and goes back to the right atrium. So we don't see a drop here because that circulation is is separate. So it comes in at 100, leaves at 100, dumps to the tissues, and then look at the oxygen in the tissues in the veins. Big drop from 100 feeding the tissues to 40 leaving the tissues. So we talked about the thickness. If it becomes waterlogged, it becomes swollen, edematous, full of fluid. And number one causes of that are pneumonia and congestive heart failure. Congestive heart failure is more common than pneumonia in the typical patient that we see on a cardiac floor or a lung floor, like the floor that I am on call at Gunderson originally. I mean, I don't work there much anymore because they're overstaffed, but most of the patients have congestive heart failure. So they have trouble breathing. That's what brings them in, is they're just out of breath. And we have to reduce the fluid in the blood vessels and around the lungs to get them feeling better. So we talked about reduction in surface area with emphysema. Those walls break down and you just don't have gas exchange. So that's going to reduce gas exchange and diffusion of carbon dioxide and oxygen. So we said the PO2 in the tissues is going to be the lowest because that's where it's constantly being used, right? So it's always lowest in the tissues, and where is carbon dioxide the lowest? What do you think? Where's carbon dioxide the lowest? In the alveoli and in the arteries, right? Because as it's leaving the alveoli, the carbon dioxide has been blown off and, again, diffuses until it doesn't anymore, right? Because it's a concentration pressure difference. So it's going to diffuse out, and then as it leaves the lungs, it's going to remain there until we add more to it from the tissues. So it's lowest in the alveoli and pulmonary vein and arteries, because we're not going to add to it until it gets to past the tissues when we're adding more. Okay, so PO2 is always lower in the tissues. That's just a repeat of that. So how do we transport oxygen in the blood? Before we talk about that, I want to show this animation here from McGraw-Hill. So I'm going to pause my video as you watch that animation that is in the Blackboard folder. So when we look at how oxygen is...
You haven't had a break in like forever, so you search for a beach vacation. Sunny
Beach vacation, that sounds good. Okay, oxygen, how it's carried in the blood. 1%, 1.5% is dissolved in the plasma, just floating around. And 98.5% is bound to this molecule we call hemoglobin. So here's a red blood cell, and it has a hemoglobin molecule in it. And each of them can bind to 4 oxygen. So oxygen binds to hemoglobin. And there's lots of hemoglobin molecules in a red blood cell. So when you put an O2 sat monitor on someone's fingertip, you're measuring how much oxygen is bound to the red blood cells in hemoglobin. So most of our oxygen is carried that way. But when we look at a person's lung function, we want a really accurate measure of oxygenation. This little bit that's in the plasma, this 1.5%, doesn't seem very important, but it's what we measure when we look at a person's lung function. So that's what this is, the 98.5%. But out in the plasma, we have this O2 floating around out here in the plasma. So this is the ISF, right? So out here in the ISF, the interstitial fluid, which is the plasma of our blood vessels, the liquid part of our blood, we have some oxygen. And this is when we look at an arterial blood gas, we're looking at how much oxygen is here dissolved in the plasma. So even though it's a really small amount, it's really important in measuring lung function. So 4 oxygen per hemoglobin molecule, most of it is carried by hemoglobin. And what's nice about that, it's kind of like a school bus, that if something happens to the airways, we've got these school buses loaded with oxygen, that if the tissues start to get starved for a brief period of time, like sleep apnea is a classic example, we're going to unload oxygen from hemoglobin to feed our tissues during that brief period of time that there's no fresh air coming in through the airways. So we have about 5 minutes. Same thing when you have a heart attack and those heart cells are starved of oxygen because there's a clot in a coronary artery. Hemoglobin is going to dump oxygen to make sure those tissue cells are fed. And we have about 5 minutes before cell death occurs and brain death occurs, right? So we need to intervene within 5 minutes to restore that flow of oxygen. And that's where the compressions come in. So that 98.5% is what we measure with the O2 sat. So when we look at how hemoglobin and oxygen interact, is we find that hemoglobin becomes more attracted to oxygen if O2 levels are high. So it's going to hang on to hemoglobin if we don't need, hemoglobin is going to hang on to oxygen if there isn't a high oxygen demand in the tissues. So what are you doing, do you think, when hemoglobin affinity is high? Sitting or exercising? Just sitting around, yeah. So the affinity, it's going to hang on to oxygen unless there's a need, then it's going to dump. So this chemical reaction of hemoglobin binding to oxygen depends on the needs of the body, and there's factors that affect it. And again, it depends on what the body is doing. So looking at the curve for oxygen and hemoglobin, it has an S shape. And here it is. So it's a little flat, and then it binds very quickly as long as we have resting tissues. And then when the percent of hemoglobin, so if we get to, if we look at this bottom thing here, when we have a PO2 of 40, when it gets low, we see a steep drop in unloading of oxygen. So what is the O2 saturation at here? If we draw a line across, my O2 sat is about what? 75%? That's pretty low, isn't it? Yikes. So we see a rapid dumping of O2 to the tissues when my O2 sat gets low. So does oxygen levels determine the dumping? Not necessarily, not right away. Not right away. We don't really feed the tissues until those oxygen levels get really low. That's the key point here, is our if you look at like 100%, like from 90 to 100, our hemoglobin molecules are fully saturated at rest. But when we get really low, we have that bond between hemoglobin and oxygen weakens, and we dump rapidly to the tissues, but not until we get to a lower level of oxygenation. So now we're going to look at what that means. Is when we increase temperature, hydrogen ion or partial pressures of carbon dioxide, and you don't have to worry about this, this is something in the blood. We see a big shift in this curve, and we see more dumping. So this curve shifts to the right. So if I take this curve and move it this way, we're going to see more rapid dumping of the tissues at higher PO2s if we're exercising. So anything that causes a right shift of this curve is going to cause more dumping and unloading of oxygen to the tissues. And a student once said a good way to remember this is right shift happens with exercise, and we know that exercise is right for the body. Okay, right? So exercise is right, and it shifts the curve to the right, which means we have more dumping, we have a weaker hemoglobin oxygen affinity, weaker bond between the two. Anything that shifts it to the left strengthens the bond between hemoglobin and oxygen, increases that affinity, and we have less unloading to the tissues. So that would be the opposite. So decreases in temperature, decreases in hydrogen ion, decreases in CO2. And think about what an increase in CO2, I mean, do you get hot when you exercise? Yeah. Do you produce more hydrogen ion when you exercise? Yes, because you're producing more carbon dioxide, which is converted to carbonic acid. So yes. And you produce more carbon dioxide when you exercise, right? Because you're metabolizing more. So that all makes sense that we would, if we're being really active, we need to feed those tissues with oxygen. So that's why the curve shifts to the right, and we have more dumping occurring. Shifting to the left is when we're resting or when temperature is going down. And what do we do to people when we want to preserve the brain During surgeries, we pack their armpit and groin with ice. It's called induced hypothermia. We bring the core body temperature down to make sure the cells are less active, and we preserve brain function that way. And that's something that we do in the hospital. And it shifts the curve to the left, hangs on to the oxygen because the cells don't need it, because the cells are not as active. And that's why kids that have fallen through the ice, do you ever watch any of those movies of kid falls through the ice and he's down there for half an hour, they bring him up and they can revive him after a half an hour? That hemoglobin curve shift to the left, the cells metabolically slowed down, less oxygen needs, and the brain survived. So that's lower temperature. So now we got to think about, now we have a patient with a fever with bad lungs, fever due to infection. Are they going to have higher oxygen needs because of that fever? Yes. Do we see rapid breathing with fever in children? Yes, because they're losing oxygen because of that shift, that weakening bond between hemoglobin and oxygen, feeding those hard-working tissues, and fever causes that. So the term hypoxia means low oxygen. So when you have patients that need supplemental oxygen, it could be from anemia, too few red blood cells, or not enough hemoglobin. When we measured those things, what do we call too few red blood cells? What measurement did we talk about in lab for those of you that had lab on Monday? Which one of those? Remember the term that measures red blood cells? Starts with an H. Very good. Hematocrit, low hematocrit. And that can be caused by bleeding from surgery. It can be caused by pernicious anemia, where you have insufficient intrinsic factor in your stomach cells, and as a result, you don't have a good vitamin B12 absorption, which promotes red blood cell production. Abnormal or too little hemoglobin, that can be too low iron, because iron is necessary for hemoglobin to bind oxygen. It's a central part of that hemoglobin molecule, so if we don't have good iron, we don't have good oxygen binding and low hemoglobin. Blocked circulation, well, that's clots, right? Any kind of clot. Metabolic poisons, that would be like, the strychnine, anything that causes the pH to change in the body is going to change the affinity of the hemoglobin oxygen curve and result in hypoxia. Pulmonary disease, obviously if the oxygen can't diffuse, can't get to the blood. And carbon monoxide. Remember we talked about, well, in lab we talked about that last week. Carbon monoxide binds to hemoglobin better than oxygen. So it kicks oxygen off and binds to hemoglobin. So when I do an O2 sat, they're going to look great, 100%. But it's measuring the carbon monoxide binding to the hemoglobin, not the oxygen. So we have to look at the PO2 in the plasma. We have to measure that. That's going to be low in someone with carbon monoxide poisoning. So we have to look at that 1.5% in the blood. Carbon dioxide is different. Some carbon dioxide is bound to hemoglobin. Some is dissolved in the plasma along with oxygen. And we measure that in an arterial blood gas. This one here is arterial blood gas measurement. But this big one here is bicarbonate ion. And where is bicarbonate ion formed? Do you remember? Yes, it is in the stomach, right? When we're pulling off that hydrogen ion to make HCl. But the blood cells, red blood cells, have that special enzyme called carbonic anhydrase, and that's where bicarbonate ions are formed. So I think we have that. Is it in the next? Yeah, right here. So we'll just look at this real quick. So carbon dioxide and water forms this chemical reaction to form carbonic acid, and some of that carbonic acid will break apart into ions, which is hydrogen ion and bicarbonate ion. And this occurs most of it occurs in the red blood cells because the red blood cells have this enzyme, carbonic anhydrase, which causes this reaction to occur, to cause carbon dioxide to come together, and then the breaking up into ions is a result of just ionization in a solution. It's just a chemical concept. So in our systemic capillaries, bicarbonate ion, because it's produced there, it's in higher concentration, it diffuses out of the red blood cells into the plasma, because that's where it's made, is in the red blood cell, so it's going to diffuse out. But it is water soluble, so it doesn't just diffuse with no energy. It needs a transport protein to leave the red blood cell, and it does that with chloride. Remember we talked about that? In the parietal cell, there's this antiporter that exchanges bicarbonate ion with chloride because they're both negatively charged, so we can't change the charge within the cell. So if we lose a negative ion, we got to gain a negative ion, and that works with chloride. So carbon dioxide is being produced by metabolism in the tissue cells. Remember we said PCO2 is highest in the tissue cells. It diffuses into the plasma, enters the red blood cell by diffusion, right? This is just natural diffusion, high concentration, low concentration. Enters the red blood cell. Here's that carbonic anhydrase that forms carbonic acid, and then by natural chemical ionization, it breaks into these ions. And here's that special transport protein where chloride ion enters the red blood cell and it's exchanged for bicarbonate ion. And then that bicarbonate ion is carbon dioxide. And the reverse occurs up in the lungs. So this is down in the tissues. So this is tissues to blood. And we're just going to write that down in case you're not seeing the relationship here. Tissues, so this is body tissues in the blood. This is where that exchange is. So this is body tissues where we're just metabolizing and making all this CO2. Then when we get to the alveoli, so now this is the blood. To the alveoli, exchange. Now we take this bicarbonate ion and we reverse it. Bicarbonate ion goes into the red blood cell. Chloride is kicked out. We reverse the reaction. So these ions form bicarbonate ion. We reverse it. We form CO2, and we blow it off in the lungs. So the reaction is reversed when we go to the alveoli. So we form bicarbonate ion in the blood at the tissue level, and then we reverse it and turn it back to CO2 so we can blow it off. So does it make sense if I'm really metabolically active and working really hard, I'm going to make lots of bicarbonate ion, am I not? Yes? And if I have lots of bicarbonate ion in the blood, when I get to the level of the pulmonary capillary, it's going to feed into this reaction and push it this way. If I have a lot of bicarbonate ion, it's going to go that way and turn it back into CO2 to be blown off. So if I measure the arterial blood of someone with crappy lungs, they're going to have a really high bicarbonate ion because they can't blow it off in the lungs as CO2. It's stuck in the blood as bicarbonate ion. So that's a big thing we measure when we measure the blood of a person with bad lungs. We're looking for what their bicarbonate level is because it can't leave the lungs. Make sense? It's a pretty advanced concept, but all I want you to basically know is CO2 leaves the tissues, is converted to bicarbonate ion in the red blood cells, travels up to the lungs, leaves the blood, and goes back to CO2 in the alveoli to be blown out. So it's just converted temporarily. CO2 to bicarbonate ion, back to CO2 out. That's the big picture, okay?